Hello, everyone, and thank you for attending today's webinar, Evolve Beyond Brick and Mortar, Impacting Total Cost of Care with a Virtual Delivery Network, presented by Solera Health. I'm Rebecca Kushmiter, and I'll be hosting this webinar. Just a few housekeeping notes before we begin. You can read full speaker bios on the left side of your window by selecting the Speakers tab, and to access additional resources from today's presentation, you can click the Handouts tab right next to the Speakers tab on the left side of your screen. For closed captions, you can access them from the bottom right corner of the video player. This webinar is being recorded. It will be available to watch on demand within 24 hours. And we would love to hear from you. During the presentation, please submit any questions you have using the Questions and Answers tab on the left side of your screen. Time permitting, we will conclude with a Q&A session. All right, I'd like to introduce Ted Hong, Executive Vice President, Chief Engagement and Marketing Officer at Solera Health, who will be moderating the webinar. Ted, please go ahead.
Great, thank you so much. So before we jump in here, I know there's the speaker bios, but I'd like to introduce the folks that are joining us today so you have some background on who's going to be helping me handle the subject today. So I'd like to kick off by having John Santelli, Solera's Health CEO, give a quick background.
Thanks, Ted, and it's a pleasure to be here with all of you. John Santelli, Solera CEO. I've recently retired from a long career at United Health Group, 37 years. In the last 20, I was the Chief Information Officer at United Health Group, and found my way to Solera over the last 7 months and have been very excited about the work that is being done here at Solera. Looking forward to this discussion.
Great. Byron?
Great. Thanks, Ted. I'm Byron Crow. I'm the Chief Medical Officer here at Solera, a practicing internist by background, based out of Boston, and I oversee our clinical organization.
Thanks, Byron. Ed?
Hi, everyone. Really excited to be here. Ed Leibowitz, Chief Strategy Officer at Solera. Been with the firm for about 4 years now, after about 20 years at leading and commercializing various different digital health products.
Thanks so much, Ed. And Zishan?
Hi, thanks everyone for watching this webinar. Zishan Sayed, the CEO of Health at Scale. We're a healthcare machine intelligence company based in Silicon Valley with a focus on real-time context-aware intelligence for care management, care delivery, benefits administration. In addition to Health at Scale, I've spent many years in academia, was a tenured faculty member at the University of Michigan, then spent a few years out at Stanford, core focus on healthcare, AI, machine learning, data science for the last 15 plus years.
Great. Thanks so much, everyone, for the introduction. So let me just tee up what we're going to cover today and kind of how we arrived at the subject matter. So industry-wide, we know in healthcare that we're seeing costs surging. Some estimates are showing as high as an increase of 50% by 2025. Obviously, employers and health plans face real mounting pressure to manage these costs effectively. At the same time, we're seeing gaps in access to care, shortage of primary care physicians, and the rise of virtual offerings brought on by necessity during COVID and really continuing into today. Solera put in the legwork, and we partnered with one of the most reputable healthcare analytics firms in the industry, Health at Scale, run by Zishan, so to help us quantify the potential for reducing the total cost of care and how it can be achieved. So today we're going to try to cover the highlights from that project and hopefully glean three distinct things. So one, how leveraging virtual networks and value-based models can really help us reduce cost. Two, how use of virtual networks can ensure patients get the right care at the right time for chronic conditions. And three, how virtual networks can boost health program engagement really for better outcomes. Why don't we kick it off with John? John, help us understand, how can virtual care serve as more than just really a supplement to traditional healthcare models, and why now?
Yeah, thanks, Ted. That's a very important question. I think if you look kind of historically at digital health over the last 10 plus years, probably closer to 20 years now, it's really been mainly focused around wellness. And I think what you're seeing now with the billions of dollars that has been infused into building out these more intelligent digital health solutions, that we're moving and expanding from wellness into what I would say specialty care. So if you think about where this is going, you're getting AI, machine learning, LLMs, helping to really increase and improve the capacities, the acuities of what these digital apps can serve. And so you're seeing now a shift that these apps, these digital health solutions, are meaningful care providers. And I think that it's changing very rapidly. And I think it's going to increase and accelerate with LLM technology as we go into the future. So what does that mean? That means that there are real care delivery capabilities, just like the brick and mortar or on-premise care. And they have been traditionally treated and been reimbursed kind of as an administrative cost, something that's additive versus being a real care provider. And so when you think about reimbursing digital health services in an admin per member per month or per encounter per month, they're really out of the gate adding cost structure. Now, back when it was wellness, that was fine. These were kind of supplemental capabilities. Now that they're really delivering true care, I think where we're heading is these digital apps are going to be treated like brick and mortar in the sense that you're going to build networks. You're going to figure out how to reimburse on benefit, not adding care on top of the benefit, but actually making these apps feel more and more in terms of a reimbursement perspective like a brick and mortar would be from a revenue cycle perspective. So I think it's really important because as they move up the acuity ladder and help deliver more capabilities, more health care to patients, they're going to be reimbursed. And by getting them on benefit like brick and mortar, by organizing them into a network like the brick and mortar traditional on-premise care, I think that's where this is going. And I guess I would just end with, as you think about these individual apps, they're very good. They're all incredibly capable, but they usually address a condition or two, whereas this network approach allows us to build a number of conditions, a broad network, kind of like payers do with traditional on-prem care, a broad set of conditions, a broad set of providers, and with that girth, the ability to handle more utilization, you're going to see the ability for this network to actually deliver good quality care, almost instant access because they're virtual capabilities, national, usually in their geographic coverage, and they are a lower cost of care service, which we're going to take you through in more detail today. So you think about this, digital care is becoming part of the healthcare delivery system proper. And so by building digital delivery systems that can be part of the overall healthcare delivery system on benefit, reimbursed like brick and mortar care, there's an opportunity for that delivery system to address access issues, to address the national kind of coverage, and to help with costs. As Ted said before, medical costs are continuing to rise. It's very frustrating in the environment today. Everybody's trying to figure out ways to help reduce medical costs, but continue to provide good care. I think a digital network on benefit with the breadth and depth that could actually deliver true care as we get more mature up the acuity ladder is going to be increasingly important in the next couple of years. Turn it back to you, Ted.
Great. Yeah, thanks, John, for level setting all of that. So if it was that easy, I think everyone would do it. We know we're not going to be able to just flip a switch and make it happen. So it's clear there's going to be some barriers to adoption and making this happen. Maybe let me start with you, Byron. What are some of the common misconceptions you think about virtual care that might limit its adoption?
Yeah, it's a great question, Ted. I think there's two major barriers that are, in particular, I wanted to call out. So the first is this idea that virtual care is somehow different. And I think John alluded to that nicely, that it's not the same as the care we deliver in clinic, that it's working around the system. It's a different modality. It can't get the same types of outcomes. It can't address the same types of patients. And I think what we're finding is that's increasingly not true. Actually, virtual care is able to provide much more care and improve quality in ways that are unexpected, while also being able to address a whole new set of patients who otherwise don't have their needs met in the traditional in-person system. I think the other barrier to adoption is this notion that, well, if I add digital care, I'm adding cost. And I'm just layering on more cost on top of this brick and mortar system that I have. I have this great network. Why do I need more virtual care? As you'll see when we go through our analysis, when you pay on claims, like we do at Solera, rather than an admin fee, and when you implement these solutions in a way where you're substituting for brick and mortar care rather than just layering on top of brick and mortar care, you actually are able to offset a pretty significant amount of cost, get it on the benefit, and then reach a new group of patients who are able to be better served in virtual, and then get their disease under control and get to a better health state, all of which cumulatively adds up to that 2 to 3% savings that we're going to about in the next hour.
Great. Thanks, Byron. And I think you'll see this clear theme throughout this presentation, that it's not just the advent of virtual, but there's really a difference between looking at it as a single solution versus our unique network approach. Maybe, Ed, you can touch a little bit on sort of how can healthcare providers shift their perspective from viewing virtual care as just this isolated solution to really recognizing it a full impact across an entire network, and why that's differentiated.
Sure. Thanks, Ted. It's interesting. If you think about the advent of digital health, it was really in response to folks with chronic conditions not getting the treatment that they needed to be provided for longitudinally. So you had a bunch of solutions crop up that were addressing multidisciplinary care models for an individual, really in response to the traditional system and employers not being able to save cost on those rising risk members. As employers look to solve those issues, they created these fragmented islands and these silos where maybe they're contracting with a Livongo for diabetes and a Hinge for MSK, and those solutions did not integrate back into the traditional operations of healthcare. So what you had was a fragmented data model and a fragmented patient experience where administrative fees were solving chronic condition management and regular traditional care was going through brick and mortar. And now what we've seen is really a pushback from the industry. If you look at the Business Group on Health Studies or any of the other recent publications that have come out, employers and health plans are increasingly concerned that those silos in digital health are driving up cost. So what Solera is thinking about and what Solera believes is if you aggregate all those solutions, put them on a standard data model, and then have them paid for in the same way that traditional healthcare is paid for, you break down those islands, you bring everything into the same tent, and then you can manage all those populations longitudinally. And that goes from reporting to see what is working, what's not, using virtual first to drive people into a lower cost of care setting before they go to specialists, and then supporting specialists with other digital services. So as Byron was saying, thinking about it as just delivering care and not delivering virtual care, right? Much in the same way that banking is now done on our phones, we really see that, as technology continues to increase, more and more of this will be delivered via network virtually.
Thanks, Ed. So as we go through implementation, I think it's a really, really sound idea. And even if we love the idea and payers and employers want to make it happen, we know the devil's in the details, right? And so John, you've seen so many great ideas fail at the implementation phase. So what do you think the industry has to do operationally to really embrace a virtual care approach? What needs to happen?
Yeah, great question. Well, I think there's a mind shift to begin with. Instead of looking at these as add-ons, something that's nice to have, really shifting your mindset to these are real care delivery capabilities, although they may be digital. And so I think the big shift is to first off realize that real care, real acuity is being delivered, and it's just going to become more and more sophisticated. So first off, that mind shift and kind of that vision of where things are going. I think secondly, there's just kind of a frustration in the environment around these point solutions. They're typically very expensive to integrate into payers on behalf of employers. I've seen costs up to $1 million per implementation. If you think about the volume of digital providers that are out there, that's quite an expensive feat. So operationally, how do you create repeatability, the ability to have lower cost, lower cycle time, time to market kinds of solutions out there, and your mindset around building networks, just like payers do with the physical providers. They build networks, they negotiate rates, they constantly seek high quality providers. I think payers have a role over time to do the same thing in the digital space and to really look at these digital providers as real providers, real high quality, understand their cost performance, and to treat them over time as a real delivery system. So I think there's a lot of frustration out there, Ted. I think the employers have kind of gone out on their own over the last 10 plus years and contracted many different point solutions, and they've been wonderful solutions. They're helping their employees, but some of them are very overwhelmed with managing all those contracts themselves. And so given the conditions of the medical cost pressures that are in the industry right now, I've seen more of the employers put the pressure on payers to say, hey, we need you to start managing this on our behalf. The payers are now in a response mode, trying to, kind of take on a large amount of work to satisfy. So I think the operational elements around how do you build repeatability and integration, how do you actually draw from a network approach versus an individual app at a time, and then the ability to really move these over time on benefit. And just like payers do today with their traditional on-prem providers, understand the cost and quality and really try to build the most high-performing network they can for their employer groups.
Thanks, Sean. I think that's a really good transition. I think getting into some of the details, getting into some of the weeds. So we've claimed that there's some source of savings here. So where does that actually come from? So we've had a couple of hypotheses relating to this. So first is just really changing the site of care. So maybe Byron, can you explain how substituting just site of care from brick and mortar to virtual for in-person really translates to measurable savings?
Yeah, this goes back to this idea that, well, is virtual care an additive cost? Is it just doing more? And as you'll see when we talk a little bit more about our methodology, what we find is that there's a lot of brick and mortar care that is going on in the community that we think virtual care can be a really elegant substitute for. Say, hey, you could be spending hundreds of dollars going to see doctors in person, which is what we all do, and those are great doctors. But if you provide a new option, say, hey, there's a new site of care, you can go see these same doctors or the same type of doctor virtually. Now you're able to put them in a new place to get equivalent care. They're not using in person as much, and they're using virtual more. So it's a very straightforward concept in that sense. Say, we know there are many visits that could be done virtually, could be done in a different place, and we can get someone into that site of care faster, and it's going to offset some of that brick and mortar cost.
That's great. So, Ed, similarly, we've also hypothesized how substituting virtual care really changes patient engagement. And how does that increase in engagement with virtual care really improve, not just improves chronic condition management and reduces long-term costs?
Yeah, I think, Ted, that it's a really good question, and obviously engagement is like the holy grail for getting people to take the actions that are going to reduce costs so they have behavior change. What's interesting about virtual and digital is there's so much rich data that you can get from digital engagement that doesn't exist in brick and mortar. In a brick and mortar episodic kind of relationship, the physician really only sees what that patient is doing once every 3 months, once every 6 months. As a person with type 1 diabetes, my endocrinologist only knows what we're talking about at the time of visit. But in these virtual care experiences, the people are logging activities, what articles they're reading, how long they're engaging with a health coach or a therapist, whatever it might be. And by leveraging an integrated data model that makes sense of all that data and creates it in a standardized way, that can be plugged into other intervention engines so that you can trigger case management outreach if somebody's PHQ-9 isn't improving. You can maybe navigate that person to a high quality surgeon if their virtual PT visits are not reducing their pain score. So it's understanding how to leverage the data from the virtual environment to trigger those interventions. And that's really where you can build this really connected ecosystem where brick and mortar is building upon virtual and vice versa.
That's really
Ted,
good.
Can I just layer on one
yeah,
piece
please,
to what Ed
Byron.
just said?
Yeah, please chime in.
Ed's point is well made. And in addition to that, we talked about the financial ecosystem earlier, right? In a world without ATMs, I go to the bank in a different way than in a world with ATMs. Right now I have this new option and I'm going to change my behavior. In a world without virtual care, where your only option is to go into the clinic. Many people are going to be doing that and wish they had a better way. Suddenly, when you offer a virtual option, people use it differently. And many of those people are going to be able to get, we'd say, under control, as in they're going to be able to have their condition managed more effectively, and they're going to get care when they need it more timely. And all of that adds up to, we think, better condition control over time, raising the bar for population health by implementing virtual solutions.
Yeah, I think patients are well-intentioned. They want to engage. They just need access, and it needs to be easier. And they need to make it really simple for them to engage. And I think that's what virtual care helps to bring to the table. So Zishan, we've had you patiently listening to us for about 15 or 20 minutes. Obviously, the audience is going to be interested in the methodology for the study. Can you walk us through kind of what you looked at, what assumptions were made, and ultimately kind of what insights can we gain by analyzing care trajectories? And we'll go through a specific case example in more detail.
Yeah, thanks, Ted. So, taking a step back, our goal with the study was to rigorously evaluate how a virtual delivery network would operate and what kind of results it would drive on a real-world population. And I think to start with just the concept of a virtual care network, it's with multiple providers acting in concert with each other is pretty novel. But I think what this group has done is to really take that a step further and evaluate rigorously how it would perform on a population of patients, with the patients stratified based on how a clinician would think about them and their disease trajectory and the characteristics that they have. And there are two things that you mentioned that I want to just expand on. One was the question about assumptions. And one of the things that we were very focused on when we did the study was to minimize assumptions and really make this as empirical as possible. So we used a very large set of commercial members, over 50 million individuals with almost 165 million claims, as you have on the screen. And really the whole goal was to, as we conducted the study, was to approach it in an empirical setting where we accounted for the prevalences of conditions, the acuity of the patients, how many of them had diseases that were controlled, not controlled, and really understand how a virtual care network, again, not a point solution, but a combination of providers, would deliver results for this. And what we focused on, the second thing, you mentioned, was trajectories. And that also is a key point, because we looked at not just site of care savings and, savings in kind of, the long term, as Ed and Byron were talking about it, but really we understood patients as a longitudinal construct. It was important for us to know what patients came in with, how they evolved before they came to virtual care, what happens afterwards. And as we think about sizing up what are the impact on savings in terms of costs, outcomes, improvements, really, evaluating the network requires understanding not just what happens on day 0, but what happens, day 180, day 365. So what we did with the study is really zoom in on a large representative population, understand the patients, make some minimal assumptions that were mostly related to the uptake and attrition portions, but really kind of account for as much as we could from the data itself. And then understand, as you're showing on the slide right now, what was the path that brought each individual member built up to the point where they interacted with the network. And then what happened after that point? How was the patient's utilization impacted? How was the progression impacted? What were the cost changes? And really then aggregate that all the way up from each patient within this population to kind of a network level view of performance.
Thanks, Ishan. I think that's really in-depth. And how does really leveraging this volume of claims data, so there's a backwards look and there's a forward look, how does that really improve the quality of the research?
So I think it's important, like the way this has been done historically, Ted, which has been, fairly kind of ineffective, is, if you think about how, a lot of virtual care has been evaluated in the past, usually it's been focused on a point solution. This idea of a network, I think, is a pretty novel construct, and evaluating it is, has been quite a bit of work, but I think it's sort of an important contribution to the state of the art. And I think what's historically been done is, you look at a point solution, you say, I'm assuming this is going to save X dollars. You multiply it by the number of patients in the population that have that condition, and then you just add up those numbers for all the point solutions, and you often end up with a savings estimate that is more than even the spend that occurred in the population, right? So there's a lot of incredulous, simplistic assumptions that are made. what we did was we said, let's look at this as a network. Let's actually account for the fact that there's the interplay between providers. Let's actually account for the fact that there's no such thing as an average patient. A population has individuals that are different, points of their trajectory. They have different acuities. They have different controlled, non-controlled disease statuses, different combinations of polychronic conditions. And let's actually have a real assessment on real claims, real data, real understanding of how spend has actually happened, what has been paid for what kinds of patients. Let's look at a population, not an individual. Let's look at a combination of providers interacting together than a point solution. And I think that's been the key thing that you'll kind of hear me talk about as we maybe discuss this is it's the fact that we have a real rigorous evaluation on a large representative population in real world settings. And that actually has, I think, driven us to do a conclusion, which I think is quite scalable because it's actually based on relaxing a lot of the assumptions and otherwise, imperfections that normally get made when, you start looking at care.
Thanks, Zishan. So Byron, taking a look at this, maybe you can help walk through kind of this trajectory of care and what the difference is kind of with brick and mortar and how it can be modified with virtual.
This gets at Zishan's point around the benefits of looking backwards as well as looking forwards. So the first thing we did was look backwards to ask, what conditions did patients have that they were seeking care for? So these are folks who had a claim for an office visit. They saw a physician for something. And then based on their claims, did we think that these folks were relatively straightforward or they represented a really complex case, the kind of case that's going to end up in a specialist's office and need quite a bit of attention. And then when we looked forward, we asked what happened to those patients in brick and mortar? Were they able to get their needs met? They were able to get their condition under control, or were they uncontrolled, meaning they had an escalation, whether that's they had intensification of their treatment, they had an invasive procedure, they had advanced imaging, a surgery, or an acute care hospitalization or ED visit, all related to the condition that we were studying. And in this way, we really were able to get down into the detail and ask, how many patients do we think we can impact, not just by substituting brick and mortar care, but actually changing the course of their condition and moving them from this uncontrolled state into a more controlled and lower cost, but healthier state of being. That methodology is really important because it gives us something that is repeatable and measurable over time, to Zishan's point, at the network level. So we can now look at these care journeys across an entire population of patients and see what happens at the network level that we think we can impact with virtual care, and then track that and measure that over time.
Thanks, Byron.
And if I could just add,
so maybe you can, yeah, go ahead, Joe.
Ted, if I could just add, I think it's really important that, this is a analytic that was done on the Solera network, where we have over 30 digital providers in the network that are paid on benefit across nine conditions. And so just to be clear, this is based on the network kind of as it is today, which will be expanded. So I think this will just become increasingly important in terms of what the cost saving opportunities could really be as a different delivery system. But I just want to point out, this is kind of an out of the box work that we evaluated this study on today, which is the network that Solera has been building over the last 3-4 years.
Yeah, thanks for the clarification on that, John. Byron, maybe let's continue with you. So we've talked about a 2.3 to 3.1% total cost of care savings from the research that we've done. How would you break down kind of what factors contribute most to that savings and generating ROI?
So it's a combination of the site of care savings that we talked about. So we're able to substitute quite a bit of brick and mortar care by applying virtual, and then adding on the improvements in health that lead to better disease control and that controlled care trajectory rather than that uncontrolled and much more expensive care trajectory. The contributions vary by condition, but just to give you some sense of the magnitude of the effect, and we were able to identify $79 million in potential site of care savings for a population of 100,000 patients. And then the PMPM savings from the digital conditions varied between $12 and $250 per condition. The reduction in spend at the condition level ranges from 0.2 to 3.5%. Again, that's if you just look at the individual conditions that are being managed. But when you package that all together and look at the impact of the network as a whole, you're getting into this range of 2 to 3%. These are conditions that are impacting parts of the population. A whole range of cardiometabolic conditions like hypertension, diabetes, all the way through to broad musculoskeletal care, right? Your low back pain, hip, knee, shoulder pain, and then a swath of GI, a women's health suite, as well as a mental health. And so we're looking at, to John's point, we're looking at some of the biggest drivers of population health. And as our network expands, that condition set is also going to expand. And each condition that you add, there's more site of care savings and more condition specific savings to go after as you grow the network and refine it over time.
Thanks,
Byron, one of the question that I just have, which maybe it might be helpful for you as a clinician to comment on, is these are savings over the first year. Now, presumably, the key point here is as you've impacted the trajectory of these individuals, they will continue to accrue benefits over the next year, future years, as well as the new sort of like diagnosed patients who are coming in. So, I would assume that, we looked at kind of just the first year, but the second year will have this effect plus additional patients, and that continues to build out. So just would be helpful to hear your thoughts on that.
Well, it's absolutely right.
Yeah, I think that's really important nuance to add. I think we were trying to be fairly conservative in what we were showing, but certainly there's a lot of additive benefits down the line.
Yeah, we looked at 1 year of data, and as you get into 2-3 years out or more, from the clinical perspective, those patients they're in that controlled state, which means they're not prone to using these high cost services that are driving up cost.
Yeah, I think it might be beneficial just to wrap up again with an extra layer of detail. So going through a case example of brick and mortar versus virtual. Ed, do you want to help walk us through this?
Sure. So to give some more color and clarity on the Solera network and why we feel offering multiple solutions is really what drives savings, is that while we believe every point solution is great, not every point solution is great for each person. And being able to align that solutions care model to the behavioral and clinical intensity needs of the individual really lets digital deliver more personalized care than brick and mortar would. And to be able to offer that level of personalized care, you have to offer a whole bunch of point solutions to a population and be able to manage and navigate those folks effectively. So in this example, and Byron will get into kind of the clinical care model, what we're able to do is identify and target who is right for a virtual specialty care solution. So in this instance, this is somebody who has back pain. So we've identified that they need a course of virtual physical therapy. So we have 4 solutions in our musculoskeletal network, going from a stretching app all the way up to surgical second opinion. And by identifying the needs of this individual and getting them into a more advanced virtual PT solution, but short of surgical second opinion, you're really optimizing that care journey for what that person needs and their behavioral model. Then when you have an advanced data model to support that care journey, you can then identify, is that person progressing as they need to be or not? And as they go through each of these solutions, so as you see 2 years later, the member re-enrolls in virtual orthopedic specialty program, we actually have the history on what that person did. So what did they do previously? How have they advanced? Does the care model need to be advanced? And is this a thing that needs surgical intervention where you want to steer that person to high quality, surgical centers of excellence? Or in this case, that person was able to satisfy their pain needs through, aspirin and conservative therapy. So Byron, do you want to talk about, how that would work from a clinical perspective and compare to the brick and mortar?
Yeah, it'll be no surprise. We've all seen or personally experienced or had a loved one experience a challenging journey in brick and mortar care. In this case, we had the patient example of someone with chronic back pain. They got advanced imaging. They had an MRI done. They were referred to PT, but they weren't able to go because it's hard to get to in-person PT. It's really logistically challenging. So they weren't able to complete PT. they continue to have pain, they go see a surgeon. The surgeon recommends surgery, which is done, and then the pain doesn't go away, and they have a revision surgery a couple years later. And that story plays out every day in the current care delivery landscape. That's reimagined alongside a virtual care journey where suddenly this person who was having a really hard time in brick and mortar, who was only presented with one realistic option, which is surgery, now is actually able to do physical therapy through a high quality virtual program. Who, many of those folks are going to have their pain resolved. For the ones that don't, we are able to identify that patient, get them into a virtual orthopedic specialty center, and have that shared decision-making conversation. Say, hey, is surgery the right choice for you? Here's the benefits of conservative care. Here's the benefits of surgery, and help that person make the best decision for them. But all in a much more efficient, less fragmented, less friction-inducing way than the current care journey. That's the power of the virtual delivery network.
Thanks, Byron. So just some key takeaways here. So hopefully we've brought to the forefront that there is an opportunity to have cost savings across a bunch of different chronic conditions. There's a big difference in having virtual applied, not just in isolation, but really as a network. And lastly, part of making it happen is you have to treat virtual care really as part of the core healthcare strategy, not just as an add-on, which I think probably a lot of the industry has done to date. But I think if you think about it really holistically, you integrate it into your overall approach, that's when you start to see the opportunity to get savings. I wanted to save some time for questions. We've gotten some in the feed. Let me read some of those. And if anybody wants to add some questions, go ahead. We'll take a look and try to get to those. What are some of the most common questions we see from stakeholders when they're considering virtual care? How do we address them? And maybe that's for John and Ed. You guys are most frequently in front of current clients, potential clients. What are the pushback things?
Yeah, great question. I'll start, Ed, and ask you to jump in. I think there's, like I said earlier in my opening comments, there's quite a bit of frustration out there with the point solution. They call it the point solution fatigue, where employers have done a lot over the last 10 plus years in contracting a lot of these digital solutions that quite frankly work very well for them. But as cost pressures continue to mount, especially on self-insured customers, they're pushing the payers really to do more on digital health for them, and looking for the payers to pick up a lot of this work and a lot of how these point solutions are contracted going forward in the future. So there's quite a bit of, I'd say, frustration, but also urgency as the payers try to respond to the employers and to figure out how best can they serve their employers. And as I mentioned before, these integrations can be up to $1 million each. And so I think a lot of the questions we get from payers is, how can Solera actually help integrate a better experience? How can Solera help reduce the cost of implementation? How can Solera help reduce the cycle time and the configurability of these condition networks, like Byron was talking about earlier? So the ability to meet the market, and I think our Halo product was designed just for that. And so being able to enable acceleration for payers to respond with their customers, with those providers that they've already contracted, to better technically integrate them for a better user experience, a better understanding of how they can configure certain solutions in the certain condition networks, mental health, MSK, so on and so forth, women's health, and to get data back, to actually, as Ed said, he called it the data model, but to understand the utilization of what's going on with a patient's journey, a member's journey through these digital apps. And Solera helps in that. And I think that's really an important distinction. Without that utilization data, it's really hard to understand a patient's journey, their success, and their outcomes, and whether or not there's quality in delivering this digital care to these patients. So the Halo platform brings a lot of that and trying to help accelerate a lot of those common issues kind of here and now. As we get into the discussions with payers, it leads to the Solera network, which we just spent a lot of time on, and the value of taking kind of an out-of-the-box network that's pre-configured, that's on benefit, and then having the ability to understand if there are cost reductions in the medical cost through the Solera digital network. And you can actually, we start to talk to them, and there's kind of sometimes a combination solution where they have great contracts with great providers that they want to maintain. Their customers may have great contracts that they want to maintain, and that's fine. They can be integrated through Halo and a seamless user experience. And then bringing the Solera network alongside seamlessly allows them to extend and broaden the network, perhaps deepen the network by acuity, and offer a better, more cohesive delivery system than could otherwise be offered by the payers. And then it gets into a discussion on what's the quality and what's the cost savings that this network can perform at. And so I think those are the common things that I see. And, some of this is getting into the future a little bit, but that's typically how I see these conversations go. Ed, I don't know if you had anything to add.
Yeah, John, I'd agree. And that urgency you talked about, I think, has led to really three questions. In a way, the employer market thought about digital health almost like somebody getting into golf or triathlon and bought as much as they could to get as good at the problem as fast as they could. And now they're dealing with, transparency solutions, navigation solutions, chronic management solutions, right? They have this big hornet's nest of stuff. So the first question really is like, what do I do? How do I make that easier to access? How do I make sure the right people are accessing those solutions? Then secondly, they say, okay, now that I have those solutions, how do I make them talk to each other? How can I integrate them a little bit better? And then the third is, how do I know what's working? And then frequently what will then come up is, well, why isn't my health plan doing any of this too? Right? So we look to navigate that virtual strategy with those employers, work with their health plan. Typically we'll sell through the health plan, bill that on benefit. And then as John was saying, Halo allows us to onboard a bunch of their solutions so that data connectivity can exist so that we can, help calm down the noise and actually provide that transparency for what's working and what's not.
Thanks. Here's another question I think is particularly timely. Does Solera put fees at risk for the numbers on the screen? Maybe Ed, you're smiling. Sounds like you and John are both smiling. It's timely.
With my
Do you
CEO
want to jump in?
I better let John answer that one first before I put my neck out there too far.
We want to go in that direction. We actually just put our first proposal with putting fees at risk, and looking at shared savings approach with the savings that have been had. And we believe the analytic engine that was created to do this assessment, this analytics, also can be on the backside. In other words, after claims are paid, to assess cohort comparisons to actually compare those that receive care digitally versus those that actually received care on-prem through traditional care, and really what are the cost differentials around that. So we are now prepared to do that, and we have our first proposal out, and that is the direction I'd like to go in, because I think payers need help, employers that are self-insured need help. I think you have a very potentially high-performing network that is a new lever in the medical cost kind of playbook that could be very helpful at a time when medical costs are really rising very high. So great question. And the short answer is yes, and we're just early in our journey.
And I would say that the exciting thing about that journey is, as opposed to the industry standard of putting outcomes for the specific solution at risk, right? Diabetes solutions will put A1C reduction at risk, let's say. The fee structure that we're looking to is really to put fees at risk based on total medical cost savings, which is what folks are after anyway. So it's a little bit less of that regression to the mean problem that I think sometimes happens with population analytics, because we're talking about true dollar savings.
And don't forget this: when you use the Solera network, you're not paying additional costs out of the gate in an administrative bucket like the PMPMs or the PEPMs. So it's an on-network benefit. So it's not like you're paying additional costs for this, and we're still willing to go at risk for it.
Yep. Here's another question, which I could probably start with an answer and then other folks can jump in. John, you just mentioned your provider network, 30 that are on benefit. Do you feel contractors can yield the same outcomes and engagement? From my perspective, I think they certainly can. And in a lot of ways, we get better engagement because, one, it's a network. So we actually get data across providers. We're matching them better to acuity. And it's a curated network. So in order for those providers to stay in our network, they have to continue to perform. It can't just be a PMPM, and they're held accountable for numbers that we can compare against other providers. So there's a lot of real world data behind all the information, not just a PowerPoint slide where they claim that they're getting these amount of outcomes. And Ed, you've contracted and negotiated with a lot of the folks who ever get into our network. Please add anything to that if you can.
No, that was well said, Ted. I mean, the data we collect from each point solution allows us to really honestly assess how they're performing. And we hold them accountable for specific outcome standards. And that's what allows us to do this pay for performance model that John was referencing before earlier, where as opposed to doing a PMPM, we actually identify the activities that an individual takes within an application and bundle those into codes when enough meaningful activities for that individual have occurred. So it's really a pay for performance model. So when you take that, and that's how our vendors get paid, you really align incentives across all stakeholders and ultimately deliver an improved care model.
Yep.
Ted, I'll just add one other piece to what Ed's.
Yeah, go ahead, Byron.
If you think about the network working together and the ability to have folks do a program and then easily move into other parts of that network and easily move into the network, out of the network within brick and mortar, that capability is unique to a network. You have to have the network in order to do that. And so, yes, the contractors can, they're delivering great programs. So I don't want to say that they're not, but there's unique effects of the network approach that are only going to improve outcomes and engagement over time as the network and all of its different interconnections are put to the full use that that's possible out there.
Yep. This one's probably a good one for you, John. Pam asks, what are your thoughts on virtual care health plans? In your opinion, will they be a new employer offering we see in the future?
That's a really great question. One I've been thinking through myself. I think there could be. If you look at some of the products that are out there that are narrow network solutions offering waiver of patient disability if they stay within the narrow network. I think something, then that they've had some very good success with those kinds of products in the marketplace and have yielded good quality providers at lower costs. I think when you look at digital, there could be a combo platter of a digital first network and maybe a narrow network solution, and with the same approach of waiving patient responsibilities to stay within that network. And I think time will tell how fast we could get there, because I think the acuity of the abilities of these digital providers as they rapidly increase, I think it becomes more and more of a reality. And if we really can perform 200-300 basis points lower on cost, I think it could be a very attractive product. Great question.
Yeah, let me see. Melissa has a question. Where do you see digital care fitting into pop health and value-based care, integrated versus standalone risk arrangements? These are great questions, by the way. Thank you so much for being really engaged. Anybody want to?
Well, I think we have a value-based arrangement pretty well set up through the Solera network, since Solera holds the contract, and it is basically a pay for performance. So Solera or the digital providers don't get paid if, like Ed said, the member does not progress through the application, actually have success and have outcomes. I think it gets very confusing around how does it fit into existing value-based care relationships that may exist with traditional care environments. And I think that's some new territory that we've been thinking through, because I think over time, digital will just be part of the delivery system, and whether it's digital or brick and mortar care over time, I think it's not gonna matter from a reimbursement perspective. So I do think there are opportunities to actually be included in some of these value-based care arrangements that the payers have. But again, the payers are not thinking that way yet, but I do think they will get there eventually. And I think those are constructs that may be advantage for some of these digital providers to move to these kinds of arrangements versus a PMPM model, which I think is going to be tough in the future given the headwinds of MLR. Great question.
Yeah. Anybody else want to add anything?
I'll just take one other angle, which is this gets at John's point that these solutions are currently viewed as different and other rather than a regular part of the benefit on par with the kinds of services that are offered in current brick and mortar networks. And so when I think about value-based care delivery and integrating virtual into value-based care, it's really of trying our best to avoid creating this idea that this is something else, that it's so uniquely different that it needs its own set of rules or ways of thinking about it, rather than, hey, how can we take these services and integrate them alongside the things we're already doing today using the same types of mental frameworks. And that's going to be able to bring virtual care more on par with in-person and get folks used to this idea that, hey, these are the same types of services. They're just in a different site of care.
Got it. Tom asks, so if engagement is driven by claims, how do you engage members in preventative programs before a claim is generated for an individual who may benefit from a program such as diabetes prevention? I can touch on this a little bit. So, Tom, our legacy, just as the company was founded, really is in DPP. So when it first got approved by Medicare, so there's different kinds of engagement. So obviously there's known risk and clinical targeting where we do get information triggered by claims, but we've also done a fair amount of unknown risk, right? Particularly on something like diabetes prevention, where a third of adult Americans are pre-diabetic, but only 10% know it. So there's a lot of outreach that is done to get folks to basically take an assessment to see if they actually are pre-diabetic. And we've actually found that to be quite successful. It's a really simple 1-minute quiz that's scored to determine whether they're pre-diabetic. And we get actually quite good engagement into those programs. And then once they're in the programs, we start to get more and more information about them. I don't know if, Byron, you have anything to add there.
I think to your point, there's claims-based engagement. Hey, we know something about the member from their claims experience. We can outreach and get them involved. And then there's a whole bunch of folks who are in a plan who we're not going to be able to identify their need through claims. We need to go ask them and get let them tell us that they have a need and then enroll them in a program. So it really is that multi-pronged approach. In this analysis, we obviously looked at claims, but there's other patients in the population that are not reflected in our analysis that have a need that you can additionally capture and get care, point toward the right care. So we do it both ways.
Yep. And just last couple of questions. Do you service all 50 states? Does your network cover all lines of business for payers? I don't know, Ed, do you want to tackle?
Yeah, we do service all 50 states. We are primarily focused on commercial. There are a handful of our point solutions that can do Medicare and Medicaid. Commercial has been where we've focused our efforts, though.
Great. I think that's all we had for questions to date. Thanks so much for the time.
There was one more.
Really...
Hey, Ted, there was one more I think is important on the prior auth. How far upstream is making a connection? Yeah. I think, Ed, it'd be great for you to...
got it. Yeah, let me read the question. So how far upstream is Solera making a connection prior to prior auth? What's the average time? Sorry.
Sure. A really interesting question. Typically, with GLP-1s, we're encountering prior auth a bit more. But historically, when you think about the breadth of the Solera solution and the great job that Ted and his engagement team are doing in reaching out to the entire population, we can intercept an individual far ahead of them needing a procedure or needing specialty medication. Secondly, we are able to intercept at the prior auth feed, let's say for a GLP-1, and intervene with educational content to explain to that person, what it means to go onto a specialty drug, what some of the other options are. But that breadth of our model really does allow us to get very far upstream, capture kind of those rising risk or those unknown risk members, before they do have a serious complication and wind up getting into a specialty pharmacy medication.
Really good. Okay, I think that is all of it.
There was one
thanks.
more from Nathan. Love to hear more detail around the assumed $79 million savings for site of service care, primary inpatient facility, ER, office. I think that's a great question that we should maybe Byron or Zishan.
I can take that.
Yep.
So the 79 million in savings, we broke up savings into two broad categories. When we say site of care savings, we're referring just to outpatient encounters. And so that 79 million reflects the total potential outpatient encounters that we think we could substitute to a solution. And then the amount of that that's actually saved depends on your assumptions around how much is actually substitutable. What we found was about half of that number ends up being substitutable in our current model. And then there's additional savings around acute care, like Nathan pointed out in his question. We included that in our controlled and uncontrolled savings. So when members have an acute care hospitalization related to their condition, that savings would fall into that controlled, uncontrolled state. And we did that so we could look at those two things differently. Say, hey, we want to know, how many just regular office visits do we think we can substitute with virtual care? And then how much savings do we think we can get by keeping people from getting worse, keeping them better with virtual care?
Zishan, you want to add anything to that?
No, I think Byron summed it up. I think we really kind of focus this just on the E&M piece, and I think there is a substantial, tail effect with the outcomes, which in fact, as we were discussing, will continue to grow over multiple years. But the 679 million was just based on those clinic visits and services associated with those that were reduced.
Great. Okay, I think this time for real, that is all the questions. Sorry, and almost right on time. Thanks again, everyone, for spending the time with us, and please feel free to follow up. If there's any more questions, we're definitely happy to engage and chat with you guys.
All right, well, thank you all so much, and thank you for attending today's Fierce Healthcare webinar and submitting so many great questions. I would like to thank our speakers for participating in Solera Health for presenting today's webinar. A recorded version of the webinar will be available for you to access within 24 hours using the same audience link that was sent to you earlier. Thank you once again for joining. We look forward to seeing you at future events.